Lipidemia signs. So basically, we have three distinct signs. The first one is xanthomas. They are plaques or nodules composed of lipid-laden histiocytes in the skin. So basically, it's this A. So this is a lipid laden histiocytes in the skin. They could be plaques or nodules. In this case, we can see probably nodules. So especially in the eyelids. So if it's in the eyelids like this, it's called xanthelasma. So this is the xanthelasma, and it's over here in the image. So for the tendinous xanthoma, this is a lipid deposit in tendon. So probably not in the face. It's just, for example, this is the hand over here, and this is where the lipid is existing, and lipid is depositing in the tendons, especially Achilles tendon and finger extensors, especially Achilles tendon that is in the foot, and the finger extensors. For the corneal arcus, it's lipid deposits in the cornea, common in older adults, so older people, put that in mind. That's why it's called arcus senilis. Arcus senilis, from senile, that is old. But appears earlier in life with hypercholesterolemia, but it could happen earlier than just an adult person, an old person. It could happen earlier in life with hypercholesterolemia, with people who have hypercholesterolemia. And this is the image. It's really nice here that this is the white lining that is the corneal arcus, also what is called arcus senilis. So that's for the hyperlipidemia signs. So that's what we can see actually on physical examination, which we can look for in physical examination. But here we're going to talk about the arteriosclerosis, and it's like a process of a disease. So that's something different. It's not a sign. It's something that explains what is happening in the body. So in arteriosclerosis, just as what the name says, it's hardening of arteries. It just, the vessel gets hard, not flexible. Usually the vessels are flexible and soft, but this one gets hard. So with arterial wall thickening and loss of elasticity, the same thing. Arterial wall thickening and loss of elasticity. For arteriosclerosis, we have like two major categories: the arteriosclerosis itself and the Monckeberg sclerosis. For arteriosclerosis, it's common, okay, and it affects small arteries and arterioles. So it's not the big or like the large or medium arteries. So we have small arteries and arterioles, and two main types. There is the hyaline and there is the hyperplastic. So for the hyaline, there is thickening of vessel walls secondary to plasma proteins leak into endothelium in essential hypertension or diabetes mellitus. So basically, this is an image A, and this is the vessel wall as it seems. And it's getting thicker, so basically this does not look normal. It should be a lot thinner than this pink wall. This happens because the plasma proteins they do leak into the endothelium itself. In the layers of the vessel wall in patients who have hypertension or diabetes mellitus. So if it's hyperplastic, then it's onion skinning, as in B, and it happens in severe hypertension with the proliferation of smooth muscle cells. So that happens in severe hypertension, that is the hyperplastic, with proliferation of smooth muscle cells. So this is the onion skinning. I think it makes sense because it looks like circles, so it's just like the layers of an onion. So it makes sense. One of the reasons that this onion skinning is happening because there is a proliferation of smooth muscles, so they're increasing in size and layers, and that's it. So for Monckeberg sclerosis, it's also called medial calcific sclerosis. So this is something that is important. It has two names. Also called medial calcific sclerosis. It is uncommon. That's why it's different. It's uncommon and affects medium-sized arteries because it's M and then there's another M, so it's easy to understand. It affects medium-sized arteries. The calcifications of internal elastic lamina and media of arteries. So basically there is calcification where exactly in the internal elastic lamina and media of arteries. So let me see if I have here. So this image does show the layers of the vessel, any vessel out there. So this is the tunica. There you go. The tunica adventitia is the outer layer. The tunica media is the middle layer. And the tunica intima is like the internal layer of a vessel. So that makes sense. Then let's go back. There you go. So in case of Monckeberg sclerosis, the calcification happens in the internal elastic lamina and media of the arteries. So it leads to vascular stiffening without obstruction. So basically it's just stiffening in the walls. There is nothing obstructing the blood from flowing inside that vessel. But what's happening is that the walls of that vessel are losing their elasticity. So that's why it looks like pipe stem appearance on X-ray. Does not obstruct the blood flow, as I said, and intima is not involved. So the very inner layer of the vessel wall is not involved, like the visceral side face is not involved. So this is the image to know. This is pipe stem appearance. This is what's called pipe stem appearance on X-ray. So that's good, but it's uncommon. So that's to be known. Now let's move to the vascular emboli syndrome. So there is microembolization of cholesterol displaced from atherosclerotic plaque in large arteries. So there is a source of atherosclerotic plaques, okay, like one that is occurring in a large artery. Usually the aorta, because the aorta has most of the plaques. So what happens is there is a teeny tiny piece of this plaque gets detached, and then it's called now a microembolization, like a microemboli that moves around because it detached from the main atherosclerotic plaque in the large arteries, just like the aorta. So this results because it moves in the circulation and goes to different organs. It could cause an end organ damage due to small artery emboli because it's just going to, even though it's tiny, but it's tiny compared to a large artery. If it goes into a small artery, then it would cause obstruction. So that's why it causes end organ damage due to small artery emboli and an inflammatory response. Because, when there is embolization, it's not only obstruction, there is an addition to that, there is an inflammatory response. So that inflammatory response, for example, is livido reticularis, digital ischemia, and that is blue toe syndrome, and acute renal failure, cerebrovascular accident, and gut ischemia. The pulses remain palpable because larger arteries are unaffected. So we said that the microembolization over here goes to the small arteries. So it causes small artery emboli. So that the larger arteries still has its own pulses because they're not affected by this microembolization. So that's why we still can see the pulses remain palpable in the larger arteries, of course, not the very small teeny tiny arteries. May follow invasive vascular procedure. The whole thing of the cholesterol emboli syndrome could follow invasive vascular procedures just like angiography, angioplasty, and endovascular grafting, because it makes sense. If we're doing any of these three procedures, we're basically inserting a catheter or a small device in the arteries, like from the femoral or in the veins or anything, but somehow it just flows into the blood, and when it goes into the blood, for example, this is the device, and there we have atherosclerotic plaque. So somehow it may rupture a small teeny tiny part of that emboli, of that atherosclerotic plaque, and be considered as microembolization that moves around freely to different